Okay. So that's kind of, again, kind of a different look at our beta blockers, and our molecular target was really inhibiting the amount of calcium inside that myocardial cell. All right. And there's another drug class, the calcium channel blockers. Oops, I keep hitting the flash drive with my thigh. There's another class of drugs. I didn't hit it. There's another class of drugs that inhibit calcium, and those are the calcium channel blockers. And so mechanistically, it's very similar, but with some slight nuances.
So our L-type calcium channel blockers, I think we know what those are going to do to the action potential conduction velocity through the AV node. Because I just asked you what would they do, and nobody wanted to answer, so I had to give it to you. But remember that calcium carries the upstroke in the AV node and the SA node. Okay? So in that respect, it's equivalent to sodium channels in the other tissues like nerve and skeletal muscle. And so when we talk about reducing sodium channels, we talk about reducing action potential propagation in nerve and skeletal muscle. When we talk about reducing calcium channels, we talk about reducing action potential propagation in the AV node and the SA node. Okay? So if I block calcium channels, I'm going to slow conduction through the AV node, and I'm going to increase the threshold potential, make it less negative in the SA node. Because again, the calcium channel is carrying this upstroke. And if I have few of them available, then I have to open a higher percentage of them to get to the point where I've got that regenerative reaction going. Where calcium comes in, that increases the voltage, it opens more calcium channels, that increases the voltage some more, right? So that threshold potential will become less negative, harder to get to. It'll slow your heart rate if you've got a tachycardia, supraventricular tachycardia, okay? It will also decrease the velocity of conduction through your AV node because you're blocking calcium channels. They're the equivalent of sodium channels in the AV node. So if I have an atrial fibrillation where that wave of depolarization is going around and around and around and it's randomly hitting the AV node and it's causing a tachycardia, an irregular heartbeat and a faster than normal heartbeat, which would be typical, then a calcium channel blocker can help because it'll increase the decrease the velocity of action potential conduction to the AV node. It'll increase the AV nodal delay. It'll increase the refractory period in the AV node, and it'll prevent action potentials from getting through for a little bit of a longer period of time. Okay? So it's useful for supraventricular tachycardias, especially atrial fibrillation, something you'll run into a lot. Okay? My dad has it. The odds are good somebody, you guys know have it.
And so we've been talking about the calcium channel antagonists. And so our target here is going to be to reduce the AV nodal conduction velocity, and that's going to result in a much larger P to R interval on the EKG. And our prototype drugs include verapamil. Ooh, is that coffee? You good? Our prototype was verapamil and diltiazem. At least it was towards the end. Okay. So let's just quickly kind of summarize verapamil. Verapamil blocks those active and inactive L-type calcium channels, and that's going to have direct effects on the SA and the AV node. So now the tissues are going to fire frequently. The activation is going to depend on the calcium currents, and these tissues are going to be less completely polarized at rest. We're going to see peripheral vasodilation. Diltiazem can be useful in supraventricular arrhythmias, so atrial arrhythmias, and also in the context of high blood pressure and angina, right? And so if the patient has an arrhythmia, angina, and elevated blood pressure, diltiazem or verapamil would be a good drug to use.